the mortality and the morbidity because of type 1 diabetes is still very, very high in India as compared to Western countries. In one of the recent IDF data that was published, it shows that the life expectancy of somebody at 10 years of age with type 1 diabetes in India is just 35, 40 years, which is almost 70 to 80 years in European countries. So kind of it tells us, it was an eye opener session which tells us that we have a long way to go in care of children with type 1 diabetes. Then the second session was by Dr. Sameer Agarwal, where he tried to tell us that uh, is that not all children with who come to us may actually have type 1 diabetes. There are some other variants of diabetes which can come. We need to differentiate pancreatic diabetes, and also sometimes we see malnutrition related diabetes which can behave very, very similarly to type 1 diabetes, but then they are very, very brittle as compared to type 1 diabetes. Now the major problem that we have now started seeing is between age group of say from 18 years or 15 years or so till 25 years or so, because earlier we used to think that all children with diabetes which gets onset less than 25 years of age are type 1 diabetes. With obesity, with increasing prevalence of type 2 diabetes, which is essentially genetic in nature, which conglomeration of more uh, risk factors being there. So now the type 2 diabetes we very, very commonly see in age group between 15 to 25 years of age or so. So sometimes that becomes very, very difficult for us to differentiate. How do we go about it? And just to summarize kind of how I believe we should go about it is, so see, what we need to look at is we need to look at signs of insulin deficiency, absolute insulin deficiency. Now, the signs of insulin absolute deficiency clinically would be uh, rapid onset, which is type 1 diabetes, loss of tremendous amount of weight loss. So, like children in 15, 20 years of age would lose 8 to 10 kgs. So, then that would be your type 1 diabetes. Of course, if children are already thin, if they are not obese to start with, or they're not overweight to start with, the weight loss quantum may be much lower. So rapid onset, weight loss over last 2 to 3 months, and then you look at your urine ketones. Urine ketones, if they are moderate or more than moderate, they tell you that there is an absolute insulin deficiency. And then you can further subsequently look at C-peptide. And I can kind of give you an example of case that I just saw 4 days back. 21 years old fashion designer student comes to us with new onset diabetes. She was having osmotic symptoms. She had rapid weight loss in the sense that she had around 10 kgs weight loss over last 2 months or so. Now, the thing is that the child was 21 years old, you can say adult also, but kind of this same case can happen at 16, 17 years of age also. So, but the person was overweight to start with. The baseline weight was 89. Now the 89 came down to 77 in 2 to 3 months. We did urine ketones, which were 3 plus. We did a C-peptide, which is 0.6. Now this is a truly case where you can't, even with all this data, I would say nobody can really say whether this will turn out to be type 1 diabetes, type 2 diabetes, and it may also turn out to be LADA case. And to tell you truth, patient came to me first. I I did not give them any type 1 or type 2 label. Then they went to another endocrinologist who told them it's type 1 diabetes. Then they went to a third endocrinologist who told them the child in all likelihood has a type 2 diabetes. So what we can practically glean from this case is 21 years old, HbA1c 13, rapid weight loss, osmotic symptoms, urine ketones 3 plus, and C-peptide 0.63. First of all, at this moment, practically speaking, at this moment, the child or the person has insulin deficiency, which cannot be corrected by drugs because our ketones are already large. Losing rapid weight, which means there is a rapid rate of lipolysis, and now this person can go into decay. And children with type 2 diabetes, 40% of them can also present with decay. So it's not that decay is uncommon type 2 diabetes when it happens in children specifically. So practically, we need to give this child insulin to start with. In all probability, if the person has enough insulin reserve, even smaller doses of insulin will lead to euglycemia. The person would start having hypoglycemias, values on the lower side, and we would eventually, over next 3 months or so, would be able to taper off the insulin completely. Now that can also be there in honeymoon phase if the person has type 1 diabetes, but then that's the time when the person is not on insulin would be the best time to evaluate, because that's going to be what your baseline C peptide is going to be. Doing a C peptide at that time would give you a fair idea as to where that person is. Another approach to do is to antibodies, as Dr. Tandon told us, that at least in traditionally we've seen that in type 1 diabetes, generally uh, uh, the consensus is that 2 or more autoantibodies should be positive. But I think Dr. Tandon convinced us with his data that just doing GAD65 would also be good enough, because in Indian subset, the data that they published, uh, anybody who had a GAD65 negative, the possibility of other antibodies being positive was little on the lower side. So just looking at cost effectiveness and then just doing one antibody may just be good enough for us. So that's the kind of age group, the kind of cases where baseline BMI is higher. So we really need to be careful before labeling any person with clearly as type 1 or type 2 at initial visit or initial 2 to 3 months. Then we went on to the core of type 1 diabetes with third session, which was taken by Vineet, in which we talked about theory of insulin therapy in type 1 diabetes. Please feel free to ask any questions, because otherwise I'll just keep on going. And if you send a question, I'll take that up on priority in the Q&A box. In insulin therapy, Vineet told us that uh, three things I think we need to remember from that session is that one, that MSI is the standard, because practically treatment of type 1 diabetes with insulin is a replacement therapy, and replacement therapy need to mirror the physiological secretion of insulin inside our body. And physiological secretion of insulin inside our body requires a basal insulin and requires mealtime insulin, which practically means that at least 4 times in a day we need to give. And any snacks which are carbohydrate rich or which require additional insulin should be given. And it's a standard worldwide. People take 5 times a day, 6 times in a day, and there is no problem doing that much. Now, one of the barriers that we uh, that we realize comes from parents and grandparents for this MSI, which they keep on saying, poor kid, hamara bacha, pyara bacha, or bechara bacha. So what I generally tell people is that, and our head of the endocrinology, Dr. Amini, used to tell us, the moment we would join a DM, she would say, first thing that you need to do, guys, is to take an insulin pen and inject yourself. Don't inject insulin, but maybe just go with the needle in and come out. You asking people to take this injection 3 times in a day, 4 times in a day, and then you need to know how much pain does it cause, how much discomfort is it, and then the same advice I give to every parents, that your child is injecting 4 times in a day. We are asking him or her to inject 4 times in a day. Take an injection yourself and see how much does it pay. The fact is, insulin pens that we use with 32 gauge needle and 4 mm 32 gauge needle are absolutely painless. Mothers inject their children when they are younger while they are sleeping, and none of them wakes up. So it's essentially a painless process. The barrier to multiple insulin injection is in our mind, and that is in our mind because of our association for potential pain because of insulin being an injectable drug. But if we take that fear away, generally it makes our life much, much, much easier. Second thing that we need to remember is that we need to set the basal dose first. Look at 4 hours post dinner dose of post dinner values, look at 2 o'clock or 3 o'clock sugar values, and then look at 6 o'clock, 7 o'clock values. All three values should be within 10% or so. If values are going up, we need to increase the dose. If values are going down, then we need to decrease the dose. Uh, so that was the how to set the basal dose, and then we also need to set the prandial dose, the mealtime dose. The mealtime dose need to be set by looking at pre-meal and post-meal values. Traditionally speaking, 2 meal post-meal should be 40 to 60 plus what your pre-meal blood glucose value was, and then you need to titrate this dose, and you need to titrate this dose by matching the insulin dose with the carbs that are there in our meal. First of all, we may fix the diet and then get a dose. Now we know that at a particular amount of insulin is required for a particular amount of carbohydrate, which gives you a ratio, and then you can start changing your food, and then you can get a dynamic ICR, and then you have got a dynamic insulin dosing. The aim of which is to keep your post-meal blood glucose values 40 to 50, 40 to 60 plus your what initial uh, uh, pre-meal values were. So those were from basics of insulin therapy, and then the practical aspect of insulin therapy was shared as a guest lecture by Dr. Vipul Jain in the group itself. So we can always look at all those, how to take injection, how to rotate sites, and what needs to be taken care for insulin syringe. A very I'll tell you a very significant anecdote, because large number of people, specifically in rural settings and in government settings, still are using syringes. So these insulin syringes come as a there are different insulin syringes that come. So two different insulin syringes which come is a 40 IU per ml syringe and a 100 IU per ml syringe. Now these syringes need to be used for a particular concentration of drug that is used in the in the insulin vials. So normally speaking, earlier the vials would have 40 IU per ml, but all the pen units would have 100 IU per ml, which does not mean any drug is stronger or not stronger. It just means how much 1 ml of that solution contains how many units of insulin. It is just a compressed solution, or it is little diluted solution. But the thing here is that both of those syringes, 40 IU per ml and 100 IU per ml, have 1 ml capacity for 1 ml. Now the one syringe would hold would extract insulin according thinking that there is it compressed 100 units per ml, and another would compressed 40 units per ml. Now I had this lady around 3 4 years back who had been had type 1 diabetes for 8 years, and she was taking 100 IU per ml insulin solution using 40 IU Sorry. Yeah, Dr. Mukesh, am I audible? Dr. Vineet?
Sir, now you are audible, sir. You are visible also, now audible also, sir.
Yeah, I am so
You
sorry.
can
I didn't get
continue.
it.
We have some question answer in the chat, question chat, I
Yeah,
think.
yeah. So let me take those questions. Hmm, okay. So no questions are visible to me, Dr. Mukesh. Can you ask the questions? Vineet, can you take those questions, please? I'm joining from phone and I think I'm not able to access those questions. Hello?
Sir, there is a question which asks postprandial glucose level are very high while fasting is within the range, then how to manage?
And postprandial, that means is that our postprandial, the prandial dose, the mealtime dose of insulin is on the lower side. So what we need to do is we need to gradually decrease our ICR, which means that the carb to insulin ratio need to be decreased so that our insulin dose would go. So for same amount of carbs, which essentially in simpler term means that we need higher amount of insulin for same amount of carbs now. So we need to gradually increase our dose. And as I was telling, the basically the way we do it is that we do a pre-meal glucose and then we do a post-meal glucose. The difference between two of them should be 40 to 60. So you increase your pre-meal percentage or so every third to fourth day till the time you reach that balance. So that's how you kind of manage your postprandial glucose values. Okay, now I can see question: how long one keep insulin injection out of refrigerator and icebox? Okay. So see, that's a very practical question, and I think we have an entire session which has been shared by Dr. Mukesh in the group itself, which is by Dr. Archana Sharda on managing insulin in resource limited settings. But specifically to answer this question, see the insulin, the vial, if stored between 2 to 8 degrees, then it is going to last till its expiry date. If it has been stored more than 8 degrees, but at less than 25 degrees or so, then this vial would last for 28 to 30 days. Any vial which has been stored more than 25 degrees or 38 degrees or so, we do not know what their efficacy is going to be. Generally speaking, the vial, the insulin pen or the vial that we are currently using, the literature in the books and everything say that they can be stored at room temperature. But what we have to understand is that all that literature is Western. In the West, the room temperature does not go beyond 25-30 degrees, while in India, the room temperature would go more than 25 to 30 degrees all the days. So what we need to understand is that the vial that we are using can be kept out of refrigerator or ice box, provided the room temperature is less than 25 degrees. If the temperature is less than 25 degrees, then this vial would be valid for another 28 to 38 days. While if it has been exposed to temperatures like 35 degrees or 40 degrees, like for example, if you leave your insulin vial in a car in an Indian summer in North India, or for that matter in South India, then even would it survive for 2 hours or 4 hours? Nobody is kind of sure about it.
Okay, so the second question is how many times blood glucose need to be tested in a day? Okay, so see, we need to test blood glucose values at least 3 times in a day. I would say at least 3 times in a day. Before each meal, fasting, before lunch, and before dinner is what we need to do. Also, because unless we know what their blood glucose values are, if we want to include some kind of a correction dose, according to in addition to the insulin carb ratio dose that we give them as a bolus dose, so then those baseline uh, uh, values are needed. Now, depending upon what other needs are, if children are feeling hypoglycemia, then it need to be tested at that time. If your fasting blood glucose is coming very high, then you also need to check midnight insulin. So midnight blood glucose value. So all those things are need based, but I would say at least 3 times in a day. And once your values are stable, then maybe once in a while you can check whether your post breakfast blood glucose values are okay. And some other day you can check post lunch, and some other day you can check whether okay or not. So those can be rotated, but at least check testing 3 times in a day is actually okay. So I think is a follow-up to the first question: is there any efficacy of insulin of defrosting? Yes, it is. The recommended temperature is between 2 to 8 degrees. See, insulin is like any protein. If we freeze it and we defreeze it, then the efficacy does go down. It is supposed to be stored between 2 to 8 degrees. It is not supposed to be frozen. So while we their insulin in the refrigerator, we specifically tell them that it should not be stored in the in freezer. It need to be stored at the door of a refrigerator. That's how it is. Okay, so uh, going back to our previous narration, I think post insulin we had a session on diet and exercise. I think the emphasis on diet exercise was that practically any diet, the restrictions of diet per se in type 1 diabetes is much lower as compared to restriction of diet in type 2 diabetes, provided we are counting all those carbs. So we should not go by the notion that the fats are not allowed to the children with type 1 diabetes. We should not go with the notion that we should prohibit any of those foods, any of those fruits to children with type 1 diabetes. All fruits are allowed. We should not be restricting their rice or even trying to restrict their butter and ghees and all those stuff. So all of them are allowed to them, provided we are able to account for the carbs that are there. Okay. Subsequently, exercise. We realize that exercise is important in type 1 diabetes for two basic reasons. Not to bring your sugar values down, that's not our primary function. But blood glucose values, they fluctuate in response to physical activity. And the action of exercise on blood glucose values is linear for first 40 minutes. The practical utility of knowing this is that, say somebody is exercising 10 minutes in a day on one particular day, and then the same person exercises for 20 to 25 minutes, say the next day. So the values of blood glucose would vary greatly. On the other hand, if somebody has been exercising 40 minutes every day and then he starts exercising 60 minutes some other day, blood glucose value fluctuations would be means that our day-to-day physical activity will impact our blood glucose values and would lead to fluctuation doing a physical activity every day. So from my perspective, I generally say that exercising in type 1 diabetes is more for stabilizing those blood glucose values than say any absolute reduction in blood glucose values that I want to achieve with that exercise. Any exercise is good. Exercise should be something that child enjoy. Any game, badminton, tennis, swimming, cycling, whatever it is, it should not be a punishment to them. They should eventually 3 to 6 months down the line, they should actually enjoy the activity and then do it. Okay, so let's go back to the questions. Child with type 1 diabetes high frequently to get an HbA1c done. 7 months is what we should do. In adults, we generally say that if your HbA1c is meeting targets, then it may be okay to do them every 6 months. Generally, in child, I would say every 3 months is what we should do. Okay, so somebody saying my voice is breaking in between. Yeah, I know. I apologize for that. I think I am not on an optimal system. There is a very, very unusual power break in Delhi at this moment. So I think bear with me and ask any point again if there is something that which I have not been able to communicate clearly. Okay, so we talked about diet, we talked about exercise, then came the time for SMBG and CGMs. So let me be clear, type 1 diabetes cannot be managed without testing blood glucose values. I think I already answered that at least 3 times in a day we need to check. CGM is a great tool. In most of the Western countries now, CGM is part and parcel of standard of care for type 1 diabetes. Even to an extent, people would say that if some kid has a choice between CGM and insulin pump, so the CGM is going to give us better results as compared to putting them on insulin pump, because it's the knowledge of the data which kind of tells you how much dose to be changed, when to be changed, when you are dipping, when you are high, is much more important. In the workshop, we discussed how to interpret those values. Just looking at those CGMS values, you can actually glean into the day-to-day routine life of children with type 1 diabetes. You can tell them where the exercise is a problem, where diet is a problem, it helps greatly in managing your basal dose and prandial doses. I think that session number 6, which Dr. Deep helped me take, was a great session on CGM and SMBG. I think all of us kind of should be looking at that session. And then in subsequent sessions, we talked about school managing diabetes at school, which again, as we kind of talked, yeah, I think Dr. Deep Datta has joined and he has very well pertinently said that that not only CGM, but now insulin pump also is a part and parcel of for all children with type 1 diabetes. And Dr. Datta is asking, is it feasible for to give insulin pump to everybody to type 1 diabetes in India? See, I think my personal view on this, Dr. Deep, is that it would be great. It is not that it does not have an incremental value. It definitely has an incremental value. But as for anything else, what we need to do is that I believe that insulin pump is just a gadget. The power lies in knowing how to use it. The power lies in knowledge of how to manage your insulin dose. And then insulin pump is a device which can make your delivery a little better using that knowledge. So we should not be giving pump to children without imparting that knowledge. If children are well versed in carb counting, if children are able to get good control or even on MSI, they should definitely go on pump. That's an incremental value and would help them immensely. Few of the condition where pump can be very, very useful is like, as we talked in that session, is early rise in blood glucose values, which starts at 3 o'clock, 4 o'clock, where it is not possible for children to have insulin injection during that time to peak, early morning peak. And then for people who have got traveling jobs, for people who've got work shifts which change every day in respect to their timing. So pumps are in a great addition for them. People who have brittle diabetes, then pumps are going to be a great addition for their armamentation. Can they be used for everybody? Yes. Once everybody is well. So that was about pumps. And then we talked about school. The thing that I was telling about schools was that as for multiple subcutaneous injection, for schools, we should not take suboptimal as granted or as a standard. We should push our schools to provide these children with adequate infrastructure, with some basic knowledge, and which does not take any extra degree or extra course or anything like that. They just need to know how to check sugars. They should just be receptive about needs. Every school would have a refrigerator, allow them to store their insulin there, give them a safe space to store their glucometers, and maybe train one teacher to check those sugar values, and then train one of those teachers, physical education teacher or the class teacher, to understand how hypoglycemia need to be treated. Basic simple understanding of these things can give huge boost of confidence to children with type 1 diabetes with respect to how can they manage. And more we talk about it, the more things becomes normalized, the stigma goes low, because then children feel if these facilities are already there, this is part and parcel of a routine care, there is nothing unusual about it, they are not being separated out about all these things. Then after school management, we talked about future directions. Dr. Atul took a great session on looking at every aspect, the newer insulins that are coming, the apps which are there to be used. In all probability, what we are going to look at is at least an automated loop in which if somebody can afford insulin and somebody can afford a system using insulin pump, then those can be linked together, and our intervention or application of our mind would go much lower, and the thing would become automatic with eventually very, very good glycemic controls that we've seen so far in children who have been using them. Dr. Yashdeep talked about reproductive life in type 1 diabetes. That was a great session. And I think that's the summary. Any more questions are most welcome. So somebody's asking, is oral insulin available? So no, let me tell you, oral insulin is not available. Inhaled insulin are available, not in India. But even acceptance of inhaled insulin has not been very good, because again, I'm telling you, and this is my personal experience, this need for oral insulin or this need for inhaled insulin stems from our own fear of injectable insulins. Thing here is that the injectable insulin is an absolutely painless process. You should inject yourself and see how much do you feel. I challenge people all the time that you would feel the fingers on your abdomen, but you will not feel the needle going in and going out. It is an absolutely painless. If you would ask me, there is no need for oral insulin. This insulin therapy is already good enough per se. And anything more than this is going to induce more problems than anything else.
Dr. Rajiv, I want to ask one practical question. How to diagnose more frequently? As a pediatrician, I see a lot of OPD, a lot of indoor also. But many times, the first time I diagnosed was only when the child already ended up in DKA. What are the practical tips for a pediatrician to diagnose more and more type 1 diabetes before they end up and it's already written on their face that they are diabetic?
Okay. So first of all, as a rule of thumb, anybody who gets admitted or in whom you feel there is a possibility of admission being required, their random sugar should be checked. In everybody, it's a very, very low cost thing, costs us nothing, and can save few lives. Second thing is that it can present in initial stages in a very, very vague manners. Children not feeling right. New onset bedwetting is a 5 years old have never wet their beds before and starts wetting their beds. And eating a lot of food, still not gaining weight. They may not lose weight, but mothers would come back and say that child is eating the entire day. And they are not feeling, they would just say they are not feeling well. They may not have any alarming symptoms at all. Nothing in urine, nothing in that. But they would say the child is eating all the day, not feeling well, but still not gaining weight. Has in fact lost a kg or two. So those are the things that you really need to look.
We should start recommending in like vital chart, blood sugar should be a important sign like heart rate, respiratory rate, input, output. We should also have a regular screening of the blood glucose in sick OPDs, and in indoor it is must. In sick OPD you have to do almost, and better if you're able to do in all OPDs.
Yeah. Adult patients we already say. That it need to be done in almost everybody. Now 25 years onwards age, you need to check blood glucose values once, and then if it is even slightly on the higher side, do it every year at least, or if it is borderline. For children, because prevalence of type 1 diabetes is still low, I will not say that every child who comes to OPD should be done, but our threshold should be very, very low. Any child which has slightly sick looking thing, just check sugars. We lose nothing doing that.
Thank you.
So I think the next question is how to convince patients to take insulin pen those are not using. I think if they are comfortable with syringe, and if they are not using pens, if their blood glucose values are okay, it is okay not to go on pens. Efficacy wise, syringes are as good as the pens are. The chances of error in pens are much lower. That's true. But I think syringes also are okay, provided the setting that you are in. And if people are already using syringes and they can afford pens, then we just need to talk. And generally the way to go about this thing, at least in my practice, is to be open about it. We tell them, okay, go ahead and use it once, and then if it is okay, then you can continue using it. I think the main barrier which we keep on forgetting is generally most of the time is the cost barrier. The new pen device would cost you around 1,000 rupees or so, which we as a physician need to take a lead. Ask any of those insulin companies to drop insulin pen samples at your clinic and make it mandatory for them to provide it free of cost to all your children, which they would happily do. And then if you give them a free pen device and ask them, okay, you use it once, it is free of cost, I think that barrier kind of disappears. Okay, so I think then there is question about best insulin pump options available in India. So see, most of the insulin pumps which are available, generally speaking, as I think I don't claim to have a great experience in using all kinds of pump in all kind of children. But generally, I would say all pumps are okay. Medtronic ones are generally the standard one. The higher you take, the more built-in algorithms are there in those pumps. The higher the pumps, I think Dr. Atul gave us a free, I think gave us a fair introduction about the cost and all those things about these insulin pumps, and you can go back to and refer that session. I don't seem to have a great kind of experience with indigenous insulin pumps, but I can tell you that a lot of upcoming startups and from tech universities, I hear a lot of good things about indigenously made CGM and pumps initiatives are being there, and I'm very, very hopeful in next 2 to 3 years we should be able to see a good amount of progress there. And I think that's it. Dr. Mukesh, anything else from your side? And I think then we can wind up this session. You are not.
Unmute kar lo, Dr. Mukesh.
Okay. Thank you, Dr. Rajiv. I think ठीक हो गया, अच्छा है, लोगों के क्वेश्चंस, क्वेरीज और जो भी डाउट्स थे क्लियर है. इसके बाद भी अगर किसी को लगता है, if somebody has more doubts, they are also we are also available on the faculty is available on the WhatsApp group also. So for the next few days, if there are some again questions, you can always be happy to clarify them. And we have already posted all the the 14 sessions on the YouTube channel, and you can revise the session again and again as per your timing schedules. And thank you so much, so much to all the attendees who have made this type 1 diabetes education program a very, very successful one. And at the end of the day, we are already learned a lot about type 1 diabetes. We are primed, we are empowered, and we will be able to help our patient in a better way. And I am very thankful, indebted to the team Speed. The Speed team, the course has been designed by them, conducted by them. Very, very thankful to Dr. Rajiv Singla, Dr. Vineet Surana, Dr. Deep Datta, Dr. Nikhil Tandon, Amit Lahoti, all the faculty, Asima Dabas. We are very thankful on behalf of IAP. I convey my regards and thank you so much. And I also want to thank Dr. Vipul Jain, but he is a friend and he's a उनको शौक है ये सब करने का, तो and he enjoys a lot doing all these academic activities. So thank you, Dr. Vipul, and also want to thank the office bearers of IAP Delhi for making these programs like this happening. And we have launched another program. We have launched e-neonatology certificate course. Dr. Vipul, we have already posted those program details in this type 1 diabetes group, also in other academic groups also. I would be inviting all of you to join that academic activity also. And again, thank you so much. Dr. Vipul, do you want to add anything?
No, thanks.
Thank you. So thank you, Dr. Rajiv, Team Speed, IAP, and all the attendees. Thank you so much. We'll see you in some other academic activity soon.
Thank you, Dr. Mukesh. And
thank you, boss. Dr. Rajiv, thank you so much.
Yeah, my thanks to Team IAP for providing us this opportunity to reach out to all these intelligent, dynamic, and lively people. And I think the support provided by you and Dr. Vipul Jain is absolutely tremendous. And we are very, very thankful to you. And special thanks to Dr. Alok Bhandari for always being the backbone for this program.
Thank you, boss. Thank you so much. Thank you, everyone.